To say welcome to everyone joining us this afternoon for this webinar on speech and language therapy for people who have Huntington's disease, and it's hosted by the Royal Hospital for Neuro-disability. My name's John Gregor, and I'm the education lead for the Huntington's Disease Association. Um, Huntington's is a very complex disease, as you may or may not know, depending on your background. And because of its complexity, if you're a professional working with people with Huntington's, it can be really challenging. And with that in mind, the Huntington's Disease Association has produced um, 10 guidelines covering all different aspects of Huntington's. So looking at genetics, looking at mobility, looking at cognitive changes, looking at physiotherapy, a whole range of topics. And when we produced these guidelines over the last year and a half, and we launched them last week, and I'll put a link in the chat so you can access them. But our guideline on speech and language therapy was written by our two speakers today, which we're very grateful for. And just to introduce our speakers, on your screen, you can see Erin Probert is a clinical lead speech and language therapist at the Royal Hospital for Neuro-disability. And Erin has extensive experience of working with people with Huntington's disease in a specialist inpatient setting and supporting with communication, swallowing, and decision making. And also on your screen, you should be able to see Sarah Roberts. So Sarah Roberts is a highly specialist speech and language therapist working within the NHS, and Sarah has a special interest in progressive neurological conditions like Huntington's, and has been working with adults with neurological conditions for the past 10 years, both in the community and in inpatient settings. And like I say, Sarah and Erin have written the guideline for us on speech and language therapy. So, and really today's webinar is in part to launch that and draw attention to that. So very grateful that they're able to do that today. So I'll hand over to you both.
Thank you very much, John. Yes, I'm Erin. I work at the RHN in Putney. We have a specialist Huntington's disease unit on site, which is where the majority of my Huntington's disease kind of experience comes from. And Sarah, over to you.
Yeah, so I'm Sarah. I've been working, as John said, for over a decade now with adults, mostly with neurological conditions. It's been fantastic. At the time of writing, I was working in a community-based setting, and part of that was looking after patients with Huntington's disease.
Okay. All right.
So we talk a bit about our guidelines. So it's been a long time in the making, really. It's absolutely fantastic that it was published last week. It's been wonderful to see it in its full glory. It's been a lot of hard work, but an absolute labour of love. We wanted to write this guideline to kind of highlight all the different stages of the disease and also the approaches to treatment and management. It's such a niche area for speech and language therapists. So actually, if you're involved with patients with Huntington's disease, it's amazing that you can see this guideline in its full glory. It's nice for us as well to have written it and kind of go back through what our understanding is and our research and why we're doing the things that we do. So we based it as a useful starting point for speech and language therapists. So you do need to have another knowledge. You can go and see the HDA website for more information and kind of do your own research as well. But this is a really good starting point for speech and language therapists. It's broadly based on the document by Hamilton, which, although it's based in 2012, it's still one of the most concise, amazing pieces of research and evidence. And then what we have done is dotted in more recent research as well. And then it's that synthesis of that evidence base and also our own clinical experience as well.
Thank you, Sarah. Yeah, we're really proud and pleased that the guideline's been endorsed by the European Huntington's Disease Network and also by our own college, so the RCSLT. So they sent the document out to some speech and language therapists to do a peer review and check that kind of they were happy with it as well, which they were, which is fantastic. And it's also been reviewed by a member of Huntington's disease community with lived experience of the disease. which is something that the HDA organised, which is just fantastic. Just to kick us off then, just kind of broadly seeing both communication and swallowing, we wanted just to reflect on the speech and language therapy role as kind of a whole, as a holistic thing. So we have such important skills that we bring to people with Huntington's disease, both for communication and swallowing. And Sarah and I will kind of go through some of the key areas for both of those, for communication and swallowing, as we go through the presentation today. But fundamentally, at each stage of the disease, we're trying to make the most and maximise what each individual is able to do. We're trying to help people to maintain their independence, maintain some level of autonomy. We're trying to support people to have the best possible quality of life that they can, with this, this disease that kind of, chips away at what makes people them. And giving people the best possible quality of life is a hugely important thing that we can contribute to. We help manage risks, and we might be engaged in sort of some positive risk taking, particularly around things like eating and drinking, and supporting people to keep on having access to food and drinks that they enjoy. And we're trying to help people to retain their function for as long as we can. And fundamentally, we feel really strongly that as speech and language therapists, we sort of generally bring a very sort of person-centered, holistic approach. We don't just get bogged down in kind of the physical aspects of what we can see in front of us, but we're looking at the emotional side of things, social, psychological, spiritual, cultural, sort of using a very person-centered and individualized approach, because there really isn't one size fits all for this disease and how we can support people living with it. And we hope that the guideline has sort of captured that. So I'm going to kick us off talking about communication in Huntington's. And just to say before I dive into all of that, we're very much going to give you a flavour of the guidelines today. Obviously, we've only got an hour, and we're going to talk about communication, we're going to talk about swallowing, and then we'll have some time, hopefully, for some questions at the end. But the depth and the detail is in the guidelines. So we're going to give you an overview, but please do go away and have a look at the document. John, thank you for popping the link to that in the chat. And for the detail, for the references, etc., because it's all in there. So first of all, just to touch on how does Huntington's disease impact communication? So we've sort of followed the literature and sort of broken that down into three key areas. So first of all, dysarthria. So normally people with Huntington's have sort of the hyperkinetic variant of dysarthria, so sort of excess movements, which fits with the choreic movements that people experience as part of Huntington's disease. And that can present with sort of quite irregular, erratic articulation, a lack of rhythm in the speech, erratic breathing patterns. So you might see very abrupt sort of inspiration and expiration, and that can have an impact on loudness. So some people might speak very quietly at times and then very loud at other times. And also people can have changes in their speech rate. So some people might speak very quickly with Huntington's disease. Other people might speak very slowly. So exactly how it presents varies from individual to individual. There is also a smaller subset of people with Huntington's who have a more sort of hypokinetic presentation in their dysarthria, so sort of a stiffness and a paucity of movement. So it's just to be aware that you can get different presentations of the dysarthria as well. In terms of cognitive linguistic impairment, as the cognitive function of people with Huntington's disease declines, it will impact on their language and also their broader cognitive communication skills. And there's a really complex interplay with Huntington's disease between language and cognition, and it isn't always possible to clearly differentiate which is which, because they are quite closely interlinked. People will present with problems with their understanding. So what people are saying to them, finding it difficult to kind of process that information, make sense of what they're hearing. Gradually over time, their vocabulary will diminish and they'll produce less words, shorter phrases, shorter sentences, and simplified sentence structures. So kind of the grammar starts to erode away, and sentences and phrases become much more simplistic. People can find it very difficult to generate ideas. And when they do, I find it hard to express those ideas coherently and in an organised way that we can follow and make sense of when we're listening to them speak. People might also get stuck on particular phrases, particular words, particular topics or thoughts that they return to again and again and again. So, for example, I had a gentleman with Huntington's disease who used the phrase, I love whatever it was. So it would be, you know, I love my wife, I love my car, I love food. So whatever it was you were talking about, whoever was around, he would perseverate on saying he loves whatever that thing was, and he'd get quite stuck on that and need support to kind of move on. People with Huntington's, generally their processing will slow as well, so it would take them longer not just to process what they're hearing and what you're asking of them or what you're saying to them, but also to kind of generate their responses. You'll see that slowed processing time. And people can start to present with word finding difficulties where perhaps they know what they want to say, but they can't access the words they need to do so. And then the third broad area that we've broken the communication deficits down into is challenges with social interaction. So the cognitive impact of Huntington's disease, coupled with the neuropsychiatric elements, so things like depression and anxiety of Huntington's disease, again, interplay together and can cause quite significant difficulties with social interaction. So this can present in a broad variety of ways and will be different for different people. So some people might present with apathy, so a reduction in their emotional responsiveness. They might not respond emotionally like they would have done before, how you might expect them to. Low levels of motivation and sort of withdrawal from interacting with others and not sort of, you know, following up on social opportunities and opportunities to interact and engage with other people. They can experience changes in their initiation, so they might find it very difficult to kind of initiate an interaction and get things going, or to initiate a new topic and keep things moving in a conversation. Impulsivity and sort of lower frustration tolerance that people with Huntington's can experience, again, can impact on how they're interacting and how they're sort of presenting within a conversation. They might present with behaviours that challenge. So some people with Huntington's disease might sort of have behaviours that, again, that frustration tolerance can come into that. They might get quite frustrated if they're not being understood, or the person they're communicating with isn't giving them enough time to kind of work out how they're going to get their response across. So you might have things like verbal aggression and sort of body language changes associated with that can sort of impede interactions and make people feel perhaps less comfortable talking to them. And they also will have difficulty maintaining their attention. So often people with Huntington's disease, as the disease progresses, can find it harder and harder to focus, especially if there's lots of distractions in the environment, and they might find themselves losing their focus and needing to be redirected. There are also kind of within this social interaction kind of umbrella challenges from a more non-verbal side of communication as well. So things like somebody's choreic movement, so those uncontrolled movements that people experience, will impact on things like their body language, their facial expressions, how able they are to maintain eye contact with the person they're communicating with. And those sorts of changes can impact on how the person with Huntington's is perceived by other people, and sometimes lead to misinterpretations of their mood or their intent. People can find it more difficult to use sort of augmentation to their communication. So things like gestures, things like writing, etc., can become more difficult for people to do because of the uncontrolled movements they might have and the physical challenges that they're experiencing. And similarly, they might have difficulty accessing any AAC, any communication aids that they use. And broadly, in the early stages of the disease, these sort of features might present quite subtly, but then as the disease progresses, inevitably, unfortunately, they will worsen and they will have an increasing impact on the person's ability to both express themselves and understand other people as well. So in terms of how we would advise sort of managing these communication challenges, so what people need will vary hugely over the course of the disease. So what somebody needs at one point might be very different to a future point. And obviously, like always in our practice, we're going to be guided by what that individual wants, what's important to them, and also their loved ones, because often, where possible, we are working closely with people with Huntington's broader families and friends as well, to try and support them in that sort of holistic way. Like is the case for lots of speech and language therapy intervention, there isn't wonderful high quality evidence for everything that we do, and as Sarah said, a lot of what we're talking about today we're basing on what research there is, that clinical consensus document from Hamilton, and then also our experiences and our colleagues' experiences as well. And just to say as a broad point, the MDT working, as again it is in so many spheres, is hugely beneficial. I'm not going to take the time to go through, what kinds of things a physio or an OT or a dietitian or a doctor might be supporting with, because that's in the guideline. You can go read that. But just to say that for people with Huntington's particularly, that complex interplay between the physical, cognitive and neuropsychiatric elements of the disease mean that if we work together as a team, what we're offering is more likely to be successful. So in terms of early stage management, just to zip through some of the key points really. So the person might be experiencing quite mild dysarthria at this stage and sort of mild cognitive communication challenges. They might be having some change in their interaction style and subtle changes in their behaviours that might be starting to impact on their relationships with people around them. So we would advocate for early referral to speech and language therapy. We should ideally be getting in there in those early stages, so that we can develop those relationships, we can give advice and information, and if appropriate, we can start to do some assessment. So in terms of assessment, both Sarah and I have used formal and informal assessment with Huntington's. In the guideline, we go into a little bit more detail with some examples of what formal assessment might be helpful. But assessing at kind of an early stage provides information to sort of guide your early input in terms of maximising strengths and compensating for any weaknesses, but also to establish a bit of a baseline from which to measure change. So that's important to think about. Another key thing at the early stage is to think about the impact of communication difficulties and to start to learn and understand from the person with Huntington's themselves, how is this, the changes to their communication impacting on them and their relationships. And crucially, what research does tell us is that people with Huntington's, what they perceive that the challenges in communication to be is often quite different to what their caregivers and loved ones feel that the biggest issues are with communication. So it's really important to try and tease that apart from all sides really, and look at both of those areas where we can. The intervention approach might be a little bit different in the early stages. So there is possibly, for some people with Huntington's, a little bit of a space to do more of a rehabilitative impairment type approach. So for example, for dysarthria, depending on how it's presenting and what the kind of core elements of that individual's dysarthria are, but things like laryngeal relaxation techniques for voice, exercises to try and work on the coordination of respiration and voicing can be effective for some people. Although for others, even at this early stage, it might be more appropriate to focus on things like compensation. So environmental optimization and sort of thinking about what conversational repair strategies work best for that person and their communication partners. And then, of course, giving information and advice both to the person with Huntington's and people in their environment as well. In terms of the mid stage of Huntington's, the person's likely to be experiencing increased difficulties in communicating effectively, and being able to actively listen to other people can start to be very impaired. Speech intelligibility will have continued to deteriorate and might be becoming quite difficult. That dysarthria might be quite pronounced at this point. And they're also likely, because of the cognitive changes that they'll be experiencing, they're likely to find it harder to sort of learn, recall and initiate any strategies to support their own interactions or support their own speech intelligibility, for example. So they'll become increasingly dependent on their communication partners to be the ones to use strategies and supports and scaffold those interactions to help facilitate the communication and to help make it more likely to be successful. People with Huntington's often find that their insight starts to deteriorate a little bit as well. So they might not be as aware of the challenges that they're experiencing. So they might not be as aware as they might be at the early stages of how dysarthric their speech now is, for example, and how much the other person is able to understand of what they're saying. We would advocate in terms of management that conversation partner training is really helpful, again, as it is for lots of different conditions. Obviously, as always, tailored to the person themselves and what their needs and preferences and priorities are. And again, the evidence shows us that sort of family supports in interactions can be both a barrier and a fantastic facilitator to people with Huntington's and ongoing interactions and conversations. So try and get in there and kind of maximise that, and it is very, very helpful. Consider the usefulness of reassessment. So don't just assess for the sake of it, I guess we would absolutely say. And I think what we would advocate for is just to consider whether it's likely to yield any extra information at this point that might change your management or change your advice or change your approach beyond that which you're going to gain anyway from talking to the person, spending time with them, talking to their loved ones, and sort of getting that informal feedback and those observations that we sort of naturalistically will gain just through working with somebody. So consider how useful it might be. Talking Maths is a kind of an accredited program, as I'm sure many of you know, and it can be used across a whole range of different conditions, but it's definitely one that's really helpful, often for people with Huntington's, both in terms of how it sort of scaffolds people's understanding, it reduces the cognitive demands, and sort of helps people express their ideas and thoughts as well. So that can be really, really helpful. We often use it here at the RHN when we're doing capacity assessments, for example. I've got an example here of a gentleman, just an image of his talking mat that I did with him, where he was going on weekly pub trips with one of the staff from the unit. And, you know, it had been something he'd been enjoying doing for a very long time. He'd go and have a pint and a cigarette outside of this pub, but he'd started to get really agitated in the pub and throwing himself onto the ground and sort of tipping himself out of his wheelchair. And the team on the ward just couldn't work out why this was happening. Right, you know, maybe we're going to have to cancel these visits, which felt really awful because it was something that he had really, really enjoyed. And this gentleman was very, very dysarthric, almost anarthric at this point, but cognitively still relatively able. He had been using some high-tech AAC on an iPad, a text-to-speech with a specialised prodder to access the screen. But his physical difficulties had exacerbated to the point that he wasn't really able to use that anymore. So we did a talking mat with him, and I thought of all the things I could possibly think of as to why it might be going a bit wrong in the pub. And the talking mat was so helpful. So as you can see, where he said, I agree, these are reasons that this is happening, he was getting frustrated because he wasn't being understood. He felt he was being ignored. And the fundamental reason was that he was trying to communicate. He wanted to go for his cigarette first before he had his pint. And it was as simple as that. So once we worked it out, we could get that right for him. And then he went back to enjoying the pub trips again. So it seems really simple, but it can be a really, really useful tool to do some problem solving and tease some of these things out. Total communication approach, again, used broadly across lots and lots of different, impairments and diagnoses, but can be really helpful for people with Huntington's as well. Playing to their strengths is obviously hugely beneficial. Considering AAC, we've got quite a lot of information in the guideline about specific considerations around AAC and communication aids. Both low and high tech devices and things can be really helpful for people with Huntington's, but it really depends hugely on the person's physical ability and also their cognitive status. And obviously what they can use at one point in the disease progression, they're unlikely to be able to use that later. So it's just always having an eye for kind of where is this going? How can I adapt this to try and keep it useful and functional for the person? And to support ongoing social engagement is really important. So people, will often naturally find that their participation socially will diminish and fall away for a host of reasons with Huntington's disease. But trying to kind of support people to kind of maybe adapt how they socialise and where they socialise to make it easier for them. So smaller groups, having people round to the house rather than going out to a busy place, for example, where there's lots of background noise and distractions, can be really helpful. And of course, speech and language therapists potentially have a really important role in things like mental capacity assessment. Obviously, the Mental Capacity Act, very, very clearly states that we have to use all practicable steps to support somebody to make their own decision before we can deem them to not have capacity and move into best interest decision making. So, our involvement in those assessments and support for that can be really helpful in somebody showing that they are still competent, and when on the surface it might look like they're not. And also, even if somebody does lack capacity, often as part of that work we do in the assessment process, we can tease out some preferences that can help inform that decision making, which can be really helpful. And then in terms of late stage management, the person is unlikely at this point to be able to communicate intelligibly at all using speech, and their cognition is likely to be very severely impaired. They might have some basic comprehension of very simple information, especially obviously if we support them with visual cues and context, etc. But their ability to use AAC and any other sort of compensatory techniques like gestures and writing is likely to have severely diminished and might even be impossible for them to access at this point. So we would advocate for just looking for residual skills. Is there anything still there that we can use that's communicative? So it might be a very, very simplistic communication system, such as a thumbs up or down or head nod or shake, but yes or no. Even if it's not reliable, making people aware of that, but encouraging that ongoing participation in interaction, or making simple choices, from two object items. So trying to see, is there something still there that we can use in some way? Trying to make sure people still have opportunities to communicate. So trying to maximise opportunities for positive interactions and experiences. Perhaps they can't engage in conversation anymore, but can they sit with their loved one and get their nails done or have a nice hand massage or something positive, while kind of having that kind of social sitting down together, eye contact, an enjoyable experience. And then obviously guidelines, so trying to make sure that we continue to sort of document and convey what support the person needs and what can most effectively help them, to try and keep some level of participation for as long as we can in the disease. Okay, I'm going to hand over to Sarah now, who's going to talk to us about swallowing.
Thank you, Erin. Yeah, so Erin did a fantastic cover. We're speaking very briefly at the moment, aren't we? But about communication, I'm going to try and do the same for swallowing in a bit of a nutshell. So here's a whistle-stop tour for you. Just put my slides on. Oh, I've lost control. Oh, there we go, Erin. So I'm going to start off with some stats and figures, but I promise I won't go too statistic heavy. But basically, dysphagia is prevalent in 35% of the early stage of Huntington's disease. So that's over a third already. By the time we get to the moderate stage, it's up to 94%. And then at advanced stage, it's 100%. So this just really emphasises what a key role speech and language therapists actually have. Then unsurprisingly, aspiration pneumonia is the leading cause of death for individuals with Huntington's disease. So it's really important that we take this holistic approach, and that's because Huntington's is quite unique in the fact that it's got that complex interplay, which Erin's already kind of touched on, of both those physical, cognitive and behavioural symptoms. So we're looking at how we can manage the risks associated with those swallowing difficulties and also maximising that person's quality of life. We want this person to live well for as long as possible. What can we do to kind of help them to enjoy the time that they do have? So I'm going to talk through some of the physiological changes. So we know that HD disease affects the brain areas responsible for motor control. So this is leading to those involuntary movements, as Erin's mentioned, that chorea, which can disrupt swallowing itself. And then we see the other types of impairments, including that muscle stiffness, that real rigidity, that dystonia, and also real slowing down of movement overall, that bradykinesia. So Hamilton describes some of the key swallow features. I'm not going to run through them all because they're all there and they are in the guideline as well, but I'm just going to pick out some of the key features that we all see with our Huntington's patients. So firstly, that hyperextension of the neck and the trunk. So I think we've all kind of seen, if you've been working with Huntington's patients, that head tips back, the airway opens up, putting that person at more risk of aspiration and choking. That kind of coupled with that reduced mastication, where they're not breaking down food so easily in the mouth, leaving those bigger chunks, that open airway is kind of a recipe for more aspiration, coughing, choking. One of the things we also see is that darting lingual chorea. So you might see that tongue thrusting or pumping. So food is pushed out of the mouth anteriorly and lost or spilled. This means that it's really difficult then for food to go backwards and be swallowed. So again, we're going to get a lot of that kind of hyperextension and head thrusting backwards to get that food to go down. So there's also a very rapid pace of eating, which we'll kind of cover later when we go on to impulsivity. But that kind of fast eating on top of all these symptoms, it's real recipe for us kind of needing to go in and help that person. It's very, very difficult, especially as that disease progresses as well. So you do get other things as well. So things like belching, vomiting's listed on here. It's not one that I've seen myself, but that it can happen. But if you want to have a look at the other things, just go into the guidelines as well. So we'll touch a little bit more on chorea. So not only do those choreic movements affect the person's limb control and swallow, they also are going to affect that pre-oral stage. So we need to think about how that person's using those utensils or bringing that food to their mouth. So if those choreic movements are affecting that, they're going to end up taking smaller bites of food or bigger bites of food. And that's going to be really tricky, especially when we think about choking risk and also kind of maintaining weight and adequate nutrition and hydration. So there are medical treatments for the chorea, which can help to improve that swallowing and the swallowing difficulties associated. But there are sometimes side effects that we need to be aware of. So for instance, those sedative kind of effects, or sometimes that dry mouth. It's the same with any kind of medical treatment. You're always going to have a look at what the side effect of those treatments are. So the cognitive changes that impact on swallowing can be things like difficulty engaging recommendations. So sometimes it's difficult for the person with Huntington's to understand the rationale behind something, and that's going to be worse as the cognitive progression shows itself really in the disease. It may be difficult for them to engage in discussions, and they may become less compliant with recommendations as well. So if they don't understand why you're asking them to modify texture, for example, they're less likely to be compliant with it. There is some difficulty initiating tasks as well. So, for instance, I had a lady who would take a forkful of food, bring it up to her mouth, and then the fork would just stop. She wouldn't go any further. And actually, all she needed was a hand over her fork to kind of guide it to her mouth, and that sequence of swallowing began. But every time she put that fork back down, that would be it. So we needed to guide her every single time. There's also a lot of fixation on objects and events, and that's something that I see quite a lot of, really. So I had a gentleman who was fixated on using a certain type of cup, and that's fine, but that's the only cup that he would use. And he also had a lot of behavioural changes. So he would throw that cup and it would break. And the same cup would have to be replaced like for like, which actually got really expensive because it belonged to a football club. So they had to keep replacing this particular football cup over and over. But it also kind of tells us that actually if this person is fixated, we need to think about early management and early introduction of certain things. So for instance, if you're thinking about introducing a flow rate cup, that needs to be done early on so that person's a bit more accepting and tolerant of that. There can also be fixations on other things as well. So I know Erin's mentioned smoking for her gentleman at the pub. And sometimes we find that people become fixated on these things. So I had patients who were fixated on having a cigarette after a meal time. So they would rush their meal to get through it because they knew that meant they could go for a cigarette, which meant meal times weren't protected. It was a little bit more risky. And it's working out how we can help that person. So for Erin's client, it was kind of changing the order of things around. And we need to look at that kind of holistic approach of what we can do for that person. I've also had clients who are quite fixated on things like healthy eating. So actually, if we're asking them to boost their calories, that really goes against what they've been taught before. This particular person really wanted to eat their salads and be very, very healthy, live a healthy lifestyle, but actually we're telling them to kind of eat little and often and boost those calories up. So we really need to think about that person holistically. There can be problems maintaining attention, which again is going to be those distractions, things like watching the television, talking when eating. So we need to learn how to kind of help that person and guide that person. So other things to consider are things like mood and well-being. So we know that mood affects appetite. If we're feeling down, we might not even want to eat. And that well-being overall, if you think about that social side of eating, if that person's having difficulties with swallowing, they're going to possibly be a little bit embarrassed, especially in those early stages, and they may not want to eat. And that's going to feed into that kind of not maintaining nutrition and hydration, which will lead into weight loss. So weight loss is a huge issue that we have with our Huntington's patients, and why we need to work so closely with the dietetics team. So there's a huge calorific intake that is needed, because those people are burning up so much energy, especially with those choreic movements all the time. So actually we need to put in more calories, and that just can become harder, especially as the disease progresses. We also need to think about saliva management. So that person could have a build-up of saliva, possibly caused by poor oral control, or they could have a dry mouth as a side effect of medication. So we've talked a bit about how it presents, but how do we actually manage? So I've talked here about early referral to SLT as recommended. Now, these things that we're outlining are absolutely gold standard, and we're not saying that every service is going to meet this, because I know, particularly in the community service that I was in, we would very rarely get an early referral to SLT. We had a fantastic MDT of dietetics team and specialist nurses, and they would be able to handle those kind of early stage management. But then we would get later referrals. So one of the things you can do is a detailed interview, as you would do with any new patient. It's particularly important for the Huntington's client group, though, because sometimes, because it's a genetic condition, other family members will have already been through this process. They might have seen loved ones who've had Huntington's as well. So it's really, really important that we include all the carers and we have a listen to what's happened in that case history. We should do a thorough assessment, and ideally this should be in the person's own environment. I know that our service moved towards more clinic-based service. This didn't necessarily work for our client groups, because if you think about Huntington's and that progression of the cognitive difficulties, it becomes more difficult to access those clinics, to answer phone calls, to remember appointments, and also to bring food with them to that appointment as well. So what we found was that people were coming into the clinic not bringing their own food, and then I was seeing them with something that they wouldn't really be eating and drinking anyway, and I wouldn't know how they were really behaving at home. Did they have the television on? Were they walking around when they were eating or drinking? So always try and do the assessment in the person's usual environment. Our gold standard is always to go for instrumental assessment, but that can kind of bring its own challenges as well with Huntington's client group. So it could be that that person may not be able to participate because of those choreic movements. It could be that they do not have the cognitive capacity to participate and to really understand. And also, as with instrumental assessment across the board, it is only a snapshot as well. So as the disease progresses, we might find that things change anyway. So Erin's touched on kind of multidisciplinary team working, and I'm just going to briefly mention the roles of the people that are involved, but I won't go into too much detail as it is in the guideline. So we've got occupational therapy, who can provide those specialist equipment and utensils. Physiotherapy, who help with the seating. So if you think about that hyperextension of the neck and the trunk, one of my clients really benefited from specialist seating just to bring the head forward into midline. The dietetics team are absolutely essential, as we've touched on before, about that nutrition and hydration and maintaining a healthy weight. So we definitely need the dietetics team on board. I've listed clinical psychology here, but actually our service didn't have any access to clinical psychology, but I think it would be so important, not only for the patient themselves, but for the caregiver as well. Specialist nurses are absolutely fantastic. I cannot sing their praises enough. The way they can manage the patient for us as well, and also help just with those recommendations that we've outlined, help someone to follow those. and also the medical team thinking about those kind of pharmacological management and those drugs. So really importantly, we need to think about non-oral feeding, and some services do delve into this more than others. I know Erin and I, when we were writing this guideline, we discussed that Erin's service are actually much more involved with non-oral feeding than my service was. So we know there's this deterioration of swallow function as the disease progresses, and that person will be at a higher risk of aspiration and choking on all textures, but they have to maintain that adequate nutrition and hydration. So one of those ways that we can do that is the option of a gastrostomy tube for the administration of clinically assisted nutrition and hydration. We need to remember that even if this person says they want a gastrostomy, they can still carry on eating something orally alongside. So I had a lady that just absolutely loved chocolate mousse. So she just wanted to eat chocolate mousse, and that was the only thing she ate orally, but everything else went down the tube. And it's also really important to remember that they can change their mind at any point as well. So there have been changes to case law and the guidelines. So now the guidance makes it clear that clinically assisted nutrition and hydration can be discontinued in advanced Huntington's disease, allowing that person to die without the need for anyone to go to court. And that's so essential. That's been a huge game changer as well. So we need to be able to support that person with their decision making. And it could be that it's just not the right time for them to make that decision, but we can still bring them on board to get their thoughts and ideas about what they want to do eventually. We do definitely have a role with those capacity assessments, and we also have a role with kind of advanced decision making and lasting power of attorney. Oh, my slide's stuck. There we go. So thinking about early stage management, as I mentioned, you might actually not get that many symptoms in the early stage, and that person might not be referred to you. So really, we're just focusing on advice at this stage. So it might be advice on managing textures, managing distractions, advice on resting before and after meals to conserve energy, and environmental adaptations. So that mid-stage, this might actually be the point when someone is referred to you. So I've put on here provide reassessment, but this actually might be where those symptoms really exacerbate and you begin to see those first signs of dysphagia. So at that mid-stage, it's really important to kind of consider things like the placement of the bolus, the size and the pace of feeding. We're thinking more about modifying food and fluid. So we need to look at those whole spectrum of IDSI levels, not just jumping from a regular diet to a pureed diet, what's in between. We need to think about those capacity assessments and trying those different postures. Just going to try and flick on my next slide, but there's a bit of a delay. Here we go. Consider smaller and more frequent meals. We also want to really maximise that independence as well. So we need to encourage self-feeding for as long as possible. We don't have to just jump to feeding the person. We can consider the ways and means in between as well. So for instance, we can have a flow rate cup to control that flow rate so that person can carry on drinking independently. We can also think about kind of hand over hand assistance as well. So how can we help that person to maintain as much of their independence as possible? I'm just going to pass over to Erin because she's got a brilliant example to share with you.
I wanted to share this example of this lady that I worked with quite some years ago now, because I think her particular kind of case and her needs really highlight how important it is for us as speech and language therapists to be very creative in sort of how we support these patients with Huntington's disease, because actually the kind of nice do it all kind of buy the textbook and tie it up in a nice bow doesn't actually often work for these patients, as I'm sure that anybody who works with Huntington's regularly will kind of be aware of. So this is a lady with Huntington's who was kind of like mid-stage, kind of moving towards the later stages, very, very dysarthric, essentially anarthric, but she was still very mobile. So she would get up and she would walk laps around and around and around the unit. Even at meal times as well. So she'd come and sit down in the dining room, she'd take one mouthful and then she'd be off, up like lurching to her feet and then lapping around the room. And she had some quite near miss, almost choking type episodes with that. So there was a lot of worries. Whereas actually her swallow itself wasn't too bad. It was more the behaviour that was exacerbating that risk. So obviously, normally we'd be saying, right, sit upright in a chair, no distractions, telly off, the person assisting to sit down at eye level, all these lovely things that we usually recommend as speech therapists. For this lady, none of that worked because she was going to fall over the chair, she was going to trip over the person sat beside her. So what we actually found was, as this picture shows, she was actually much, much better if we sat her up in bed. We had a television, which you can't see in the picture, but at the foot of the bed that we'd put her favourite programmes on. And the person who was assisting her, because she needed full assistance at this point, would be stood and sort of trying to crouch down to her level for actual feeding, but not sat on a chair next to her, because the risk was that this lady would fall over the chair and really hurt herself, or the person sat there. And that worked really well for her. She was able to sit for much longer. She was able to, enjoy her meals, sing a little bit more. The risks were reduced. So though it doesn't look wonderful on first glance, this looks like a terrible feeding situation, for this lady, this was what worked. It kind of was really beneficial to her. So again, just to emphasize that creativity really, and thinking outside the box for these patients.
Yeah, perfect example, because it isn't a one size fits all. Everything's got to be tailored to that person. They are unique individuals, even though we have some of the same themes that come out across the board when the disease progresses. Everybody is very unique. So just to kind of finish off there, really about late stage management. So maintaining adequate nutrition and hydration becomes so important at this point. We know that the disease progresses, swallowing's got worse, weight loss is a huge factor, so we need to think about how we're going to maintain that nutrition and hydration. There's also an increased risk of aspiration and choking. As we saw in those advanced stages, 100% of patients end up with that dysphagia. Something we went a bit back and forth on is in the original kind of Hamilton paper, it was listed the cough reflex is well preserved. However, in later research, we did find that up to 28% of people had silent aspiration. So it's just really important to be really careful and mindful that just because someone is coughing doesn't mean you haven't got another client who is also silently aspirating. So at this stage as well, people are likely to become increasingly dependent on others for feeding and oral hygiene. And we know that that can kind of lead to things like chest infections, if you think about kind of your Langmore research. So at this point, regular review of swallowing is absolutely essential. Before, it might be that you've just done a quick check-in. Now the disease is progressing, we need to check in more regularly and see what's going on. We need to continue reviewing those modifications and compensatory strategies as well. So we need to have further discussions about non-oral feeding. So it could be at this point that we're starting to introduce that and someone's having a gastrostomy, but it also could be that somebody has progressed so far that we're also thinking about stopping that non-oral feeding. As we've just touched on, we need to optimise that oral hygiene as much as possible. And we need to support caregivers throughout, because remember, that person has just watched their family member go through this. They've been there to support, and they need ongoing support throughout this journey. So really, that is kind of the swallowing side and communication side in a very brief nutshell. But we're going to open the floor now to any questions at all.